With this said, I would like to take us back to the TKIs, because there is another important story that I proudly, on behalf of all other colleagues, reported back at GI ASCO, which is on cabozantinib in a phase 3 trial, cabozantinib versus placebo, that actually showed an improvement in survival for the patients receiving cabozantinib versus, of course, placebo, which understandably was a new advent for this drug, which is a c-Met inhibitor plus a multi-TKI. Ruth, did we surprise you with that data, or is it something that you expect, or your perception?
Yeah. Cabozantinib is a very interesting drug, and if you compare all the
I only deal with interesting work.
Comparing the targets like from other TKIs, it targets MET and XL, and so those are important molecules in HCC, not only for the cancer, but maybe also for the immune environment. So there's a lot of speculation how this drug actually works, and it has to be proven to be quite a strong drug. The reason is when it's compared with, when in the second-line setting, it's compared with the placebo, show the survival benefit. But this study is a little different from the other second-line study. Is a quarter of the patients actually had 2 lines of therapy. So and then the signal is still very strong. And I think for sure, I think that has proven cabozantinib is a good, strong second-line or even third-line option for patients.
Fair enough. And yeah, of course, we were very thrilled about that positive data. Now, Manish, however, if you recall, there was this trial of a c-Met inhibitor as well, a TKI, tivantinib, but it was negative. Tell us more.
Yeah, I think that we still are trying to understand the role of MET in this disease, and I think that tivantinib, there was a lot of excitement about that. I think there was even biomarker selection going on in that study where we were actually looking for MET expression and picking those patients to try to give tivantinib. So maybe we got a little bit ahead of ourselves in the science, but the thought was that we have a target, we have a drug, let's hit it, and let's see the reap the fruits of that labor. And it turned out that that was a negative study, as you already said. And so clearly, maybe actually going after MET specifically is not the answer. So cabozantinib may have been successful in part because it doesn't only go after MET, it actually has other targets as well. And so there's always this sort of, what I've always, it has always intrigued me about tyrosine kinase inhibitors. There are some that are more specific and some that are more, if you will, dirty or promiscuous. They hit a lot of different targets. And in some diseases, it's actually advantageous to have one that's a little bit more dirty that hits many different kinases. That seems to be the case here with cabo. Like we said, there may even be an immunologic, modulation component to how cabo is working. So we're not really sure what it's doing, but the fact that it's kind of multi-targeted may be to its advantage as compared to a tivantinib, or a monoclonal, let's say, that inhibits MET might not be as successful. So different diseases. In some diseases, we've been very successful at hitting a target very specifically with either a small molecule or with a monoclonal. But in HCC, it seems actually having this broad scope and hitting a lot of different targets with these kinase inhibitors has been more successful.
I fully agree with you. If anything, as we know, the tivantinib study, at that time when they did the phase 2 data, they found that actually the c-Met specifically, if the c-Met was high, patients will not do great. And if anything, giving anti-c-Met at that time, which was tivantinib, definitely they could improve an outcome. And as such, they elected that they will only allow patients who have a c-Met positivity that were expressed at the time 50% 3 to 4 plus expression in immunostaining to be allowed to go on the study, which was negative. Interestingly, when we start working on the cabozantinib, I remember that the same question, of course, was brought up. And interestingly, however, if I were to say, like, what's the contribution that I added to that study, I said, use it for all. And if anything, really, what is the science behind that? It's not like, out of anything short of exactly as we just heard from Manish. And in other words, I'm not the only one who would think that way. We all kind of, now we do understand that multi-TKIs are actually to be really not valued based on one specific target, and same time we don't know how much of that target is going to be important one way or the other. So that's why I would say yes, the cabozantinib data was positive, and really it showed this improvement in survival that was quite impressive compared to the use of placebo per se. And I add to this that actually, at least I have the hands-on experience, but I'm sure many others have done that as well. But Mark, have you used cabozantinib at all?
So we unfortunately didn't have the trial open
Yep.
at our center. So
Yep.
in the HCC world, until it's approved, I haven't used it very much. I used it a little bit in renal cell, although I didn't.
And what's your experience?
It seems to be overly, pretty well tolerated. Similar
Yep.
side effects to what we've seen with the other TKIs. You get fatigue, you get diarrhea, some hypertension. The similar side effects. But overall, I do think it's pretty well tolerated.